Good afternoon, everyone, and welcome to our National Training Webinar, In Health Matters, Place Matters, the Health Opportunity Index. This national webinar is presented by ASTHO Center for Population Health Strategies. This is the second webinar in our webinar series, New Tools to Advance Health Equity. We have organized this webinar today in partnership with the Office of Minority Health and Health Equity at the Centers for Disease Control and Prevention. My name is Melissa Lewis, and I am the Director of Health Equity and Social Determinants of Health for the Center for Population Health Strategies at ASTHO. So thank you, everyone, for joining. And before we begin, I want to quickly provide everyone with a brief overview of today's webinar. So first, this is a part, like I mentioned, of our webinar series, New Tools to Advance Health Equity, and this aligns with ASTHO's vision for state and territorial health agencies advancing health equity and optimal health for all. And that's our new vision statement that we went through a whole strategic planning session, and it's our new three-year strategic map and vision. And I wanted to emphasize this point is that ASTHO is really committed and dedicated to making sure we support states and territories in their efforts to advance health equity. And so just to quickly go over how the day will go, I'm going to quickly just provide welcome and introductions, and then we will have an overview of CDC's Office on Minority Health and Health Equity activities from Dr. Leandris LaBird, and then we will have an introduction to the Health Opportunity Index from the Virginia Department of Health and Office of Health Equity panelist team, and then that will be a 50-minute session in which we go in depth with describing the Health Opportunity Index. And then we will have the question and answer portion and then closing remarks. And so we are so excited that the Virginia Department of Health and Office of Health Equity team will be providing this in-depth presentation. They're going to highlight how they developed the Virginia Health Opportunity Index, which is an online mapping tool that is a composite measure of the social, economic, educational, demographic, and environmental factors that relate to a community's well-being. And during today's webinar, the participants will explore how the Health Opportunity Index online mapping tool was developed. They will provide details on the data that they used to develop the tool. They will discuss cost, infrastructure needs, and associated challenges so that this can be replicated in other state health agencies. And we will also explore how state health departments can use their state data to better understand the root causes for poor health, identify inequities, and then how they can customize their interventions. And so this tool can be used to educate the community, advocate, engage payers, and new partners. So throughout the webinar, we will feature poll questions, and attendees will be invited to submit questions through our chat feature. And so there are two ways to listen to the webinar: through your computer speakers, which is the preferred way, and then also via the telephone. But you cannot you cannot use both methods because it will cause conflicts and challenges with the system. So we ask that you submit questions to the chat box online. The phone lines will be muted for majority of the webinar as the presenters are giving their presentations, and we will read the chat questions during the Q&A portion of the webinar. There will be lines opened at the end if some individuals that have called in would like to verbally ask questions, but there will also be the chat function in which we will read the questions to the presenters. So this webinar is being recorded, and the recording will be shared via email, and it will also be put on the ASTHO website, so within approximately a week. So we are really looking forward to today's webinar, and we hope that you all will benefit from today's discussion. So it's my pleasure to introduce the webinar speakers. So Dr. Leandris LaBird is the Director for the Office of Minority Health and Health Equity at the Centers for Disease Control and Prevention. In this role, she leads a wide range of critical functions in the agency's work in minority health and health equity, women's health, and diversity and inclusion management. She plays a critical leadership role in determining the agency's vision for health equity, ensuring a rigorous evidence-based approach to the practice of health equity, and promoting the ethical practice of public health in vulnerable populations. And so what we're going to do, because of the way the session is structured, is that Dr. LeBert will go first, and then we will introduce the Virginia speakers, and they will give their in-depth training overview of the Health Opportunity Index. So, Dr. LeBert, I will turn it over to you.
Thanks, Melissa, and good afternoon, everyone. On behalf of CDC's Office of Minority Health and Health Equity, we are very pleased and excited about our collaboration with ASTHO to advance health equity and to be part of today's webinar. This year is a special year for our office in that we are celebrating 30 years of service, and our theme for this year is Mission Possible, Healthy Lives for Everyone. I just want to remind some of you that of the 1985 report of the Secretary's Task Force on Black and Minority Health, which was the landmark study that continues to anchor the federal government's commitment to improving minority health and reducing health disparities. I want to share with you in terms of our anniversary that for 30 years now we've had one office with focused on one mission, which is reducing health disparities, and we believe that the mission is possible. This year I'm very excited that I am working closely with previous directors of the Office of Minority Health. Some of you will know them, Dr. Reuben Warren, who was the inaugural Associate Director for Minority Health here at CDC, and my predecessor, Dr. Walter Williams. We are working together this year to both commemorate significant accomplishments of the office as well as to celebrate public health agents of change. And I want to skip this slide and go to some of our anniversary activities. Many of you will know that we have a blog that's titled Conversations in Equity, and this year we are committing to the blog Health Month theme articles from our National Centers, Institutes, and offices that will highlight what they are doing to address health equity. In February, the focus was on Heart Month, and there's an article there that came from Dr. Ursula Bauer and the National Center for Chronic Disease Prevention and Health Promotion. You'll see for April, we focused on sexually transmitted infections awareness month as well as Minority Health Month, and there's a blog that was written by Joe Valentine, who is the Associate Director for Health Equity in the Division of Sexually Transmitted Diseases here at CDC. And so I encourage you to go look at all of those blogs and to follow us monthly. Please subscribe. We have now over 42,000 subscribers, and we welcome everyone's participation. We are also planning for our fourth Public Health Ethics Forum, which is an annual forum that we do in collaboration with Tuskegee University. And this year, the focus of the forum is on minority elders and healthy aging. It will be available virtually as well as open to the public. The date is September 14th, so please stay tuned, and we will be sending out save the dates and other information about how you can register to participate in that forum. We are also preparing our quarterly Health Equity Matters newsletter, and the one that will come out will be an anniversary edition, and will provide both historical as well as current perspectives on the work of minority health, reducing health disparities, and health equity. I also want to highlight a timeline that's available on our website, and that timeline will feature significant events that have happened across our nation that have moved issues of improving minority health forward. It starts with, let's say, 1915 and National Negro Health Week, and you will see other seminal events that we continue to build upon. I also wanted to take just a minute to share with you, those who may not be as familiar with CDC's Office of Minority Health and Health Equity, some of our priorities. We focus on solutions for reducing health disparities, improving women's health, and ensuring a diverse and inclusive public health workforce. We also work across the agency to facilitate the implementation of policies and strategies across CDC that promote the elimination of health disparities. We are the focal point here for advancing the science and practice of health equity, and we collaborate with national and global partners to promote the reduction of health inequalities. Our leadership roles include being a technical consultant for our colleagues internally as well as externally. We are a collaborator and partner with a number of national and global organizations. We are thought leaders as evidenced by the 2016 special issue of the Journal of Public Health Management and Practice that we wrote in collaboration with ASTHO on health equity. We are a catalyst for a number of reports that come out of the agency. Most recently, the African American Vital Signs report that was released last May in 2017, and we are a convener. Just a few other things to highlight. We recently launched CDC's Health Equity Leadership Network, which is a collaboration of health equity scientists and program practitioners across the agency. We continue to be involved with Healthy People 2020 Social Determinants of Health topic area, and we'll continue that with the 2030 Healthy People. We lead the development and the implementation of CDC's Language Access Plan, and we also collaborate with our colleagues in the Office of the Associate Director for Policy and in the Office for State, Tribal, Local, and Territorial Support in both maintaining and updating CDC's Social Determinants of Health website. Lastly, but not least, we support and work with ASTHO on their map, which highlights state initiatives to advance health equity. I encourage you to go to that map and click on it and to see all of the innovative and very strategic health equity activities that are going on around the country. So I want to again thank Melissa and ASTHO and all of you for being present today to be part of this important webinar.
Dr. LaBerge, thank you so much for presenting, and we appreciate your support of these initiatives. And so next I will introduce our Virginia panelists. And so we have Dr. Lauren Powell. She is the Director of Health Equity for the Commonwealth of Virginia. In her role, she leads the Commonwealth in its statewide strategic plans and initiatives towards achieving health equity for Virginia's 8.4 million residents. Dr. Powell has an established track record as a community-engaged social epidemiologist and health disparities researcher. Justin Crow, who is the Director of the Division of Social Epidemiology in the Office of Health Equity of the Virginia Department of Health. Prior to joining the Office of Health Equity, he joined as the Deputy Director for the Virginia Healthcare Worker Data Center and the Deputy Executive Director for the Board of Health Professions, both with the Virginia Department of Health Professions. Justin is most proud of his work highlighting the importance of healthcare to rural economies. And then we have Rexford Anson Thuamina. and he is the Senior Social Epidemiologist with the Office of Health Equity in the Virginia Department of Health. He has over 10 years of experience in spatial epidemiology and public health, including epidemiological methods, geospatial analysis, predictive modeling, and research design. Rex is most proud of his research into the efforts of the closure of hospital-based obstetrical services in the rural areas. Thank you all for joining us this afternoon. I will now turn over the session to the Virginia panelists.
Good afternoon, everyone. Thank you so much for joining us. I'll start off, Dr. Lauren Powell here, I'll start off telling you a little bit about the office and kind of how we came to the creation of the Health Opportunity Index. First, the Office of Health Equity, our mission is to identify health inequities and their root causes and promote equitable opportunities to be healthy. We have 3 federally recognized offices within the office, which allows us to support a robust division of social epidemiology. We're really excited and honored that ASTHO has actually honored us. We received an award, the P3 program here in our office, which stands for Partners in Prayer and Prevention, received the ASTHO Vision Award. We received first place, so we're really proud of our partnership with ASTHO and their recognition of our work here. And the award was for Category B, which was for a budget much less than $250,000, which I do want to highlight our budget was much, much less than $250,000. So we're excited about the work we're doing here and proud that ASTHO has recognized it. As we think about programs and the program that I just mentioned, the P3 program, I really enjoy this infographic from the DHHS and from CDC actually that highlights the roads towards achieving health equity. We see here illustrated 3 different roads, programs, which I just highlighted one of our programs, the Partners in Prayer and Prevention program, which works with a number of faith-based and interfaith institutions around the state of Virginia to promote health communication, measurement as a path, and then policy as a path. We're really going to focus in this discussion today about measurement as a path, really how data practices are used to support the advancement of health equity. And that's really where our division of social epidemiology comes into play as we think about the path of measurement towards achieving health equity. A little bit about the division of social epi. The vision for this particular division is information with impact. I really love that because it's our goal to improve policy and program functions using data. And so the division director, who you'll meet shortly, Justin Crow, really leads his division from the perspective of a Nelson Mandela quote, which is pictured here in this slide. It says, "A leader is like a shepherd. He stays behind the flock, letting the most nimble go out ahead, whereupon the others follow, not realizing that all along they're being directed from behind." And our vision is really to lead with data. Our strategic priorities are then to engage stakeholders and policymakers and the public with actionable information. We try to cultivate a stable workforce, develop high-quality data products, and translate then social epidemiology research to the Commonwealth. As a disclaimer, using the theme of shepherding, some of the following slides may contain sheep and goats, just to keep you all on your toes out there. So we'll first step into talking about barriers to well-being. And this poor guy here, clearly he didn't have any data to help lead him on his path, which is what we are trying to avoid here. So we're going to talk about where we are right now and some of our challenges, our barriers to achieving well-being. Currently in America's health rankings, Virginia is currently ranked overall as 19th. This is an improvement from 23. We were ranked 23rd in 2013. But here we have a chart that shows several of the factors that were used in ranking, and each factor's rank in 2013 and 2015. We remained 19th in 2017. But so if we look at health disparity, which I think there's still have a circle there. If we look at health disparity in health status or health disparity, In 2013, we ranked 33rd, but in 2015, we improved to 29th. So what's important to note here is that the American Health Rankings uses education. So they're essentially looking at no high school diploma, so whether or not you've achieved graduation with a high school diploma versus being a college graduate. In looking at sort of this issue from another perspective, we wanted to look at the Commonwealth Fund ranks for Virginia, which is now 28th, which is down from 2 points from the previous iteration. We're 44th in health disparities, which is also down from 2 points. And so the question is, like, why is there a difference? Well, the American Health Rankings uses education. So as I just highlighted in the previous slide, they're looking at the achievement or completing a high school diploma versus college graduate. And then the Commonwealth Fund looks at income, which we know is another important determinant of health. They look at those under 200% of the federal poverty level versus those over 400% of the federal poverty level. So we can tell between these two infographics that there are various ways to explore health disparities. We also look at racial disparities. Here we have an age-adjusted graph of health disparities across the Commonwealth. So we're looking at cancer, heart disease, cerebrovascular diseases, and unintentional injuries amongst white, black, and a conglomerate other group. This is age-adjusted, and so we're looking at mortality here. We can look at racial disparities through mortality. And then we can also look at broad geographic disparities here, which is showing the difference between urban and rural disparities in mortality, an age-adjusted look at that. But if we want to get closer down and looking more at neighborhood-level disparities, we're looking here at an infographic of life expectancy in Richmond, Virginia. I'm sure this is no surprise to many of you on the phone, and this certainly mirrors several other parts of our country here, that there is a drastic difference in life expectancy just based on where you live. So we see here we're looking more at neighborhood-level disparities. Between 5 miles, you have a 20-year gap between an area known as Gilpin Court and Westover Hills. So we know that 20 years is the difference between seeing kids really graduate from kindergarten and graduate from college. So this also affects kids who grow up without grandparents and thus has an intergenerational persistence here if we're looking at life expectancy differences. And so while I think that it is very troubling and disturbing that we see these disparities, it also does show us, though, the potential. So if we know that 83 years, the potential to live to 83 years is possible in an area such as Westover Hills, then we know that we have a lot of room to make an impact and improve people's lives in an area where you may only have 63 years of life expectancy in somewhere like Gilpin Court. And really what we need to be able to have that stronger impact and to lengthen the lives of individuals and improve their quality of life, we need to know the right path to take in order to have those outcomes. So our goal is then to be the healthiest state in the nation. So we want our health disparities, our disparity in health status to go really low. And the path to get there is to be equitable and to also use data to help us chart our path towards the future. So I'll pause here because we're going to have a quick poll question that I will give you just a couple of seconds to be able to answer. We'll bring that up in just 1 second.
There we go. So our poll question is, does your organization or program use a standard social determinants of health measure or set of measures to inform program activities? So it looks like the question got a little cut off there, but it's a standard social determinants of health measure or set of measures to inform program activities. So now we're getting our results in. It looks like maybe about half of the people answered yes, and half know, and then we have a significant portion with don't know, so that doesn't add up to 100%, but of yes and no, it's about half and half, so that's pretty good. And we'll go back to our presentation.
Now back to your regularly scheduled program. This is a really good segue into measurement and the importance of measurement in helping us find the path towards health equity. And the reason we pose that as a poll question is because if you're not measuring, if you don't have a measure, then you may be missing the path completely, which unfortunately the sheep or goats pictured here are completely missing the path. And we don't want that to happen in our programming or in our efforts to achieve health equity. I'm pretty sure that most of you are probably familiar with this pyramid, but I do want to highlight the quote here in blue that tells us that for single mothers with less than 12 years of education, every $1,000 increase in the earned income tax credit is associated with a 6.7% to 10.8% reduction in low birth rate. I can give you a quick description of the earned income tax credit. That's a federal tax credit for low-income workers, so it's sent with a tax return. There's no strings attached. And the whole point of highlighting this is to show that there's great impact in trying to make things more equitable for those among us in society who kind of get the short end of the stick. And I think that this pyramid shows that socioeconomic factors, as we know, are the biggest foundation to some of our health inequities here. And that if we want to increase individuals' ability to achieve health equity, we really need to address some of those socioeconomic factors. And so I wanted to highlight the path, something that we use here to help us chart our path forward in measurement, our path forward in achieving health equity is the Virginia Plan for Well-Being. It is our state health improvement plan. It's something that we have spent countless hours and resources towards creating. And it really does help keep us on track, not only as the Office of Health Equity, but as the Virginia Department of Health, on how we are going about achieving wellness and well-being for all Virginians here. Within the Plan for Well-Being, we've come to understand that well-being depends on systems of care and preventative actions. So those are the branches here in this graphic illustration of a tree. And then a strong start for children is extremely important, and that's sort of the trunk. But that really the roots of all of this are healthy, connected communities. And that's truly our foundation for working to achieve well-being across the Commonwealth of Virginia. I want to move now into discussing more the difference between, as we think about healthy, connected communities, the difference between communities of opportunity versus low opportunity communities. And we know that our goal is to provide all communities the opportunity to be healthy. And so a few of those factors that contribute to opportunity communities are things we know, parks and trails and grocery stores and social inclusion, IT connectivity, and strong local governance. And some of the things that are barriers or that contribute to low opportunity communities are unsafe and limited parks, things like fast food restaurants, we know food deserts, food swamps, few small businesses, poor performing schools, social exclusion, limited IT connections, things like this that contribute then to either poor health status, which then contributes to health disparities and health inequities, or conversely good health status if you are in a community of opportunity. Within the Division of Social Epidemiology, we've created a social determinants of health dashboard. And this really helps us kind of from a data perspective look at those communities of opportunity versus those of low opportunity. This is from more of a 30,000-foot view. Nonetheless, The dashboard contains indicators for poverty, unemployment, and insurance, cost burden households, voter turnout, so all these things that also correspond and correlate with the previous slide that we were just talking about with low and high sort of opportunity communities. So we can aggregate to broad geographic disparities such as metro and non-metro areas, and we do see social determinants of health disparities in Virginia, not unlike many other states across the United States. But it's also no secret to many of you that geographic level can certainly mask disparities. And if we're looking so far away, if we're a 30,000-foot view and we're looking at this top level of statewide by city or county, then we may be missing disparities that are happening on a more local or even neighborhood level without looking deeper, such as like a census block group, or if we could even get down deeper than that to social profiles, social networks, and social capital. As an example, this is the Social Determinants of Health dashboard, a map of the poverty rate in 2016. You can see the Southwest and the South Side, Eastern Shore, so the areas of darkest blue look like the largest challenges with poverty. In Northern Virginia, looks like they have very little problem with poverty. In fact, it's one of the best performing regions of the country on most socioeconomic measures. However, there are more people living in poverty in Fairfax County in Northern Virginia than in any other county in Virginia. So you can see here that there are roughly 68,000 Virginians. And that could totally be missed at the county level, which is, again, emphasizing the importance of getting a closer look, really using data to get a closer look at what's happening in our communities. And at the census tract level, however, we can identify the specific areas where we can reach the 68,000 vulnerable Virginians that we just spoke of in the previous slide. And the census tract is, the census is a designated unit of roughly about 4,000 people. It's usually delineated by local participants and can be as small as a single building in a very dense area or a whole county in some rural areas. So, for example, Highland County in Virginia, Shenandoah Mountains is considered, I think, a full county census tract. And it's really, unfortunately, I mean, it is. It's as close to the neighborhood level as we can get. And so we do try to use the census tract level where possible to help us get a closer look at the opportunities for the communities that we are responsible for here in the Office of Health Equity. And with that, I thank you for your attention to my portion of the presentation, and I will introduce the Division Director for Social Epidemiology, Mr. Justin Crow.
Okay. Thank you, Dr. Powell. And we're going to take a quick break to do another poll question here. Pull that up in just a second. So this question is, at what geographic level does your organization or program target health or social determinant health interventions? So is it at the state or regional level, the county level or equivalent, zip code or service area, census tract or neighborhood level, or that you just really don't target geographically when you design and implement programs? Wait a little longer for the results to come up because it looks like we get a nice graph if I wait. So there are the results. It looks like about well, people are still answering, about 28% use county or county equivalent, 27% get down to the neighborhood level. about 20% at the state or regional level, and 16 or 18% specifically look at a zip code or service area level type look, and about 8% are not targeting geographically at this time. Now we'll go back to our slideshow. Now we got backwards here. Skip ahead. Apologize for the technical difficulties here. All right, so design and methods. So how do we get down to the neighborhood level here in Virginia? That was one of our challenges so that we can address health disparities. So the way we did that was to develop the Health Opportunity Index. The Health Opportunity Index identifies areas and populations that are most vulnerable to adverse health outcomes based on the social determinants of health. So these are the 5 elements of social determinants of health from Healthy People 2020. I'm sure a lot of you are familiar with this already, but it's a wide, broad range of factors that they look at. The neighborhood and the built environment, health and health care, focusing on access and quality, differences in technical access to technology, the social and community context, education, and economic stability. Some measures of SDOH even include health disparities. So that's a broad range of things, and you can take everything in the kitchen sink out of that to try to create a single look, or when you're creating a measurement of social determinants of health. So we had to limit what we included in the Health Opportunity Index. We had a very specific process to select indicators for the HOI, for the Health Opportunity Index. The first was we developed a work group. It consisted mainly of our local health department directors and staff, as well as epidemiology staff from Virginia Department of Health Central Office, and a few stakeholders from the community. Now, the reason why it was so focused on the health department was because we had originally thought we were going to use this mainly for internal use, but it became a very popular tool that moved out of the department and is continuing to be used in different areas. So that was how we identified the factors that we wanted to include. We wanted them to be linked to the health outcomes in the academic literature. So we did a review. This didn't mean that there had to be a definite link. We just wanted to make sure that there were some articles that were supporting having the factors within the Health Opportunity Index. So for instance, our measure of inequality, or Gini Index, there are some academic papers that support the health link, and others that kind of debate that or don't find a link. But we want to include it anyway since it was important to our stakeholders. We wanted the factors we included to be actionable. So we looked at, for instance, segregation instead of race, because we all know that race isn't the cause of health disparities, it's racism. And so we wanted to focus on that factor that could actually be addressed. So that's kind of what we wanted to include. What was sort of a limiting factor on that was number 4, is we needed consistent quality data for all census tracts in Virginia. This was difficult for some key factors. For instance, we wanted to include crime. A lot of our larger police departments were able to provide good quality data at the address level that we could aggregate to census tracts, but a lot of our smaller police departments weren't able to, so we weren't able to include crime when we were developing this tool. So what did we end up with? We ended up with 13 indicators, and I know the writings here is small. I'll get into more detail on what the indicators are later. But this is just to identify the ones that are linked with the same factors from Healthy People 2020. So we have at least one indicator from each of those 5 distinct Healthy People 2020 factors, which are included in the Health Opportunity Index. So the index is structured. It includes over 30 variables, which we combine into 13 indicators. So the 13 indicators are the foundation of the Health Opportunity Index. We use them as kind of our pantry with our different ingredients to create the other top higher level profiles in the 4 profiles in the Health Opportunity Index. So these are all combined first into 4 profiles in the Health Opportunity Index. So as I mentioned, the Health Opportunity Index includes 4 profiles. The Community Environmental Profile, the Consumer Opportunity Profile, the economic opportunity profile, and the wellness disparity profile. So I think it's important to mention that these profiles were created, the 13 indicators within each profile were identified using statistical tools. Now, when you look at the list, it seems like they all go together. Like if you had to pick groups of indicators and put them together, you probably just naturally pick these. But these were actually identified by a statistical tool called principal component analysis, which identifies variables that tend to vary together. And then we had a contest in our office to name the different profiles once we put the indicators together, and these are the names we came up with. So what are the 13 indicators? The first, the community environmental profile, includes an air quality index, which includes 6 different measures of pollution at the census tract level. A population churning index, which measures the turnover of the population within each census tract, the number of people moving in and out of the census tract. Our population density indicator, which that's one of the indicators that's not really actionable, but it's an important control in the Health Opportunity Index. And a walkability index, which includes a measure of density, diversity, design, and distance to transit to measure walkable communities. The second profile is our consumer opportunity profile. This is really looking at the access to goods in the community. So we have our affordability index, which includes housing costs and transportation costs divided by average income. We have our education index, which looks at average years of schooling, and it's important to point out that this is average years of schooling of the adult population. The education measure doesn't measure the school system in the community. We get a lot of feedback on that sometimes, but it is the education level of the adult population in the community. We have our food accessibility index, which is basically a food desert measure, the same one used by the USDA, that measures the access to healthy foods by the low-income community, access to a grocery store, actually. And finally, our material deprivation index, which includes a measure of unemployment, autoless homes, home ownership, and overcrowding. And that's really a measure of accumulated wealth and consumer credit. Our economic opportunity profile includes an employment access index, which looks at the number of jobs and the distance to those jobs. So here in Virginia, here in Richmond, we have a lot of people who travel to Washington to work. It's about a 2-hour drive. So obviously they have the opportunity to access those jobs, but we count them a little less than we would, well actually a lot less than we would jobs that are actually located in Richmond, Virginia. Our income inequality index, which is a measure of the distribution of income. Basically, if you have $100 coming into the community, and you have 10 people in the community, does everyone get $10 each, or does one person get 91 and everyone else get $1? And finally, our job participation index, which is a measure of the civilian labor force. It includes both employed people and the unemployed people who are actively looking for work. And finally, our wellness disparity profile, which includes our access to care index on insurance, which Virginia has not expanded Medicaid at this moment. So that's still a factor in our state, and access to primary care within the community, and our segregation index, which if you're familiar with measures of segregation, we use a spatial disparity index. All right, now I'm going to turn it over to Rex Anson-Duamina, who's going to talk about disparities in the HOI and some of the work he does identifying those disparities.
Thank you, Justin. I would like to touch on how the HOI has been used to actually show the burden of disease in the state. But I'd like to point out that it's a model that we built, and there's a saying by George Box in 1979. He said, all models are wrong, but some are very useful. And that's how you see the HOI. It doesn't take a place of the expert opinion at the neighborhood level, but it shows you the direction where you should be looking in terms of intervention. So, like my boss said earlier, aggregation of data and disaggregation of data are not linear transformation. What that means is that if you do the analysis at the county level, you don't get the same results at the census tract level. Therefore, it is advisable to go lower census tract level and then move up. And that's exactly what we did. So to do that, we had to calibrate the model with health outcomes. And we used what we call the life expectancy as a calibrator or to validate the model. And all what we did was we geocoded every death in the state then link the geocoder data or the dev data to the census tract, and then we put them into quintiles. So if you look at the graph on the screen right now, what do we call it? Monotonic, the same as the gradient or the linear. You could see that people who were living in a low HOI area compared to those in a high HOI area, it's a huge difference between the number of years they live on average. But because we wanted to be sure that this model is calibrated and also validated, we tried so many health outcomes. So we also use what we call disability-free life expectancy. Most people live longer, but the question is, are they living in good health or healthy life? Therefore, we control for disability. You can see the same trend on the graph on the right. And then we also try it again. So in fact, we did try more than 5 or 6 times using different health outcomes. We had the same results. That tells us that the model was better. In fact, it did predict about 87% of the life expectancy. So Virginia can now predict. In fact, we have already built a model in the SPSS or SARS. We can actually predict what the life expectancy will be in the next 5 years if we have the same indicators using predictive analytics. We use the same data, as you see on the screen, for diabetes. We had the same trend. We use a COPD. We had the same trend. So that is an indication that the model was actually doing better at the lower level. But if you do that at the county level, you might not get the same thing because they are not linear transformation. You get different results. And here we also show the mortality rate based on the same thing. So if you look at the unintentional injuries, that is not there's no huge gradient, but you can still see the difference in those areas. Now, if you look at what we call PQI, PQI is the prevention quality indicators, which used to be called ambulatory care sensitive conditions. For the whole state, you see the same trend. So the HOI has been, in fact, most of the program managers in the state have used it to actually target some of the areas that they could use for intervention. Again, we had another project from Vision Zero, which is a program for Richmond City Health Department. They wanted to figure out where they should be looking or where they should go in terms of crashes, accidents, and use the same HOI to tell them where they should be looking on the map. In fact, this tells you where you should go for intervention. So they were able to identify these areas, move in before they happen. But, like I said earlier, every model there's no perfect model, but some are very useful. So this model has some limitations because we have what we call ecological fallacy. What that means is that if being a census tract, you might have some groups who are, even better than others. But that's the best we could do. At the same time, census tract might not represent a neighborhood because certain areas in Richmond have different, political boundaries for a neighborhood. And again, the source of data was also another problem. We had to use 5 years estimate from ACS data, which is the survey. And again, we want to make sure that the data has a nationwide measure, which was also limitations in the model. How do we use this? We use this model to tell us that place matters. So where you live determines your health outcomes. It's very, very important because if one at the census tract level, we're able to identify these areas compared to areas that are doing better. Second thing is that we wanted to make sure that it has a great impact on the social determinants of health. Also, it shows the landscape of the area, of the state. So it can also target. And I think that we will also be, because we have 13 indicators, like Justin said, we're able to see which of the indicators are more influential in the state at the census tract level. In fact, as a matter of fact, we can tell you for every census tract which variable or which indicator is more influential. It's very, very important. It also helps us to learn from our communities. We learn from them as well as they learn from us to understand what is going on at the grassroots, and also help us to also form collaborations with our stakeholders. Not only do we do that, I'm pretty sure most of you have learned what we call machine learning. We need to make sure that one cap doesn't fit all. So we had to do machine learning to be able to drill down to see which factors are more predictable for low birth weight. So if you look at the screen right now, we took all the data from low HOI areas. We then modeled it to show us what are the predictors of low birth weight in terms of the areas that are low opportunity, have a low opportunity. And the first predictor was race. Now, because we didn't see race in our model, we could then use that to be one of the lists, because the model doesn't have race as a white or black or other racial or ethnicity. It has segregation. So we can use that. The second predictor was a trimester, as a norm. And the third predictor was mother's age and education. That was areas that were identified as a low HOI areas. Now, if you go to the high HOI areas, different results, like I said earlier, they are not linear transformation. So if you see that you have different predictors in every quintile that you took. So if you look at the areas, the high opportunity areas, mother's age was one of the highest predictor in education, then race, then trimester. So every area, you can drill down using neural network to drill down to identify these areas so that you can come out with the best intervention to address the problem. Now, another way we also use the index is that we work with the health directors in the state. They normally call our office and say, hey, all out of the 13 indicators, which one should I be focusing on in my area? You can model the data and tell you the top 5 or the top 6 or the top 3 that you should be focusing on. So the screen tells you Norfolk City. You see that all the orange colors are their top 5 influential variables that you should pay attention to. So like I said earlier, you can build aggregate the model to the higher level, to county level, because it's the census tract level. Because census tract and counties are coterminants. Because you map them, put them on a map, and show you, overlay the two, so you can see the areas where you should be looking. Again, it's used a model of heuristic. It's a heuristic model to discover, to find out what is going on. Not only do we do that, we also use the model to show disparity or to help us point where we should place our doctors or physicians in the state. It helps us to identify these communities or these areas so that we can put our physicians and help address physician shortage in the state. And on that note, I'll turn to Justin to do some conclusion and we'll take questions from there.
All right, thank you, Rex. All right, the next thing we're going to talk about is how we make the data accessible to our stakeholders. So we do have a website where we display the Health Opportunity Index, and what we use on there is a tool called Tableau, and I'm sure a lot of you have heard of it, but it's a way to take data and really visualize it and make the visualization interactive. And we're really excited about this tool, particularly for the HOI, because it allows people to drill down, and that's one of the things we get a lot with the HOI. People will see a measure in the community and they'll have questions and they'll want to know more and want to drill down more, and the HOI gives people the opportunity to do that. So this is one of our dashboards. It's still, I was going to try to do a live demonstration, but unfortunately the server was running a little slow this morning, so I decided not to risk it. But this is one of our dashboards. The surface of it is our population experience dashboard, and as you see there's a map of Virginia colored by our local health districts. The chart on the right is called a bubble chart. See, there we go, a bubble chart. And what this shows is we divide the HOI into quintiles by census tract. So 20% of census tracts are in a very low area, very low opportunity area, a low opportunity area, an average opportunity area, and a high opportunity, and a very high opportunity area. So a very high opportunity, that's good. That's where you have the highest opportunity to live a long and healthy life. So these bubbles show the population in those census tracts. So this is showing all of Virginia right now. So about 20% of people live in census tracts with very low opportunity to live a long and healthy life, and about 20% in very high at the other end. And this is sort of the same thing at the bottom, but in a bar chart form. So the light green is very low opportunity to live a long, healthy life, and then as you get darker green, a higher opportunity, and that just shows the percentage of the population by county, sorted by local health districts. So you can click on these different local health districts, and it will actually change to that population. So the bubble chart will change, and then, of course, if you click on Central Shenandoah right here, the Central Shenandoah data will come up. You can see very quickly when you look at this that Buena Vista City in that area and Lexington City have a lot of their population live in, well, 100% live in census tracts where there is a very low opportunity to live a long and healthy life. Whereas Augusta County here it performs a lot better. The population is more spread out and more what you would expect statewide. Okay. We also have our county rankings page where you can look at where Rex has done some excellent work using some population-weighted indexes, population-weighted geometric averages to create county health ranking or county rankings using the HOI. Now, I kind of have a love-hate relationship with the county rankings because they do draw a lot of attention. It's one of those things that people come and they see and they want to drill down more to, but it also, people tend to focus on them as well rather than the targeting down into the specific neighborhoods, the census tract level neighborhoods, as well as the specific indicators that are affecting health in their communities. But it does draw a lot of attention. So this is Fairfax County. We spoke about it earlier, how it's one of the top performing counties in Virginia and as well in the nation in socioeconomic measures. But as you can see here, as you saw with the poverty level, we have most of the county, as you'd expect, is in very high opportunity areas. But there are pockets of very low opportunity, and they don't completely match the low, high poverty areas that we identified earlier, but there is definitely some overlap. So we find this pattern everywhere. That's Fairfax County. That's Richmond City. So you can drill down at the neighborhood level and really target those vulnerable populations. So Richmond City, a little more challenged than Fairfax. So you can see a lot of very low opportunity areas, but also a lot of very high opportunity areas. So as Rex was discussing earlier, the patterns it allows you to target vulnerable populations, but also kind of understand the patterns of health. You know, what causes low birth weight, and these areas will be different. And of course, we create maps specifically for our legislators, legislative districts to look at. This is one of our districts in Southside Virginia. And you can see here the same pattern in the rural areas. So you'll see some rural census tracts with very high opportunity and some with very low. It's just well distributed throughout the state. We also try to share and collaborate with partners. Some of the work that Rex was talking about stemmed from working with our local health districts, going out and doing presentations and getting questions and feedback and finding out more about what they need. We're also trying to spread the HOI outside of Virginia, or spread information outside of Virginia. So it started really as an internal tool for the Virginia Department of Health. We've since, of course, used it out in the community, and we are more and more using it, sharing it in national and regional areas. So this is just a slide done by Chip Allen, who is the director of the Office of Health Equity in Ohio, for the Ohio Department of Health, Dr. Powell's counterpart. And we actually created a Health Opportunity Index for Ohio. We were updating the Health Opportunity Index, our last iteration. We did a data exchange with him, and we were able to do that. Of course, we can't do that for all 50 states, and we certainly can't maintain it for all 50 states, so we're looking at ways that we can provide technical support and collaboration to different areas. We get requests fairly regularly to help different localities and states develop their own HOI or some version of it. So if you want to build it internally, resources needed, your staff is generally 1 through 2 epidemiologists. You can also use economists or special people who are just field data technologists and subject matter experts, particularly those skilled in geospatial techniques. We spent about $25,000 to $30,000 on software. Most of that was ArcGIS, but also Tableau. Tableau is much cheaper, and there's a free version that works just as well for most purposes. It took us about 6 months to develop. That's probably a little bit of an underestimate. If you have time to dedicate it to it completely, then 6 months is probably about right, but you might want to think about more of a year or even 2 years if you're starting from scratch. And of course, our bonus here at Virginia Department of Health is we have a lot of colleagues that we can count on, and we got a lot of free advice from them as well. So here in Virginia, we have some very good stakeholders. So we were invited to a presentation once, and it was to a rural group, and they spoke to us, they said, we don't want to hear about we don't want to hear about what's wrong with rural anymore. We want to know about solutions. So we get that question a lot. We also have a lot of questions from different stakeholders. This is great, and I understand how things like the Earned Income Tax Credit can help, but I work for a hospital, or I'm in public health, or I'm a healthcare provider. What does this have to do with me? So we always like to talk about some solutions at the very end of our presentation. We talk about measurement, or what we have measured. So just a top view of why we think this is important, and why we think the social determinants of health are important, and why you need to target them and understand them in your community. So this is a chart that I'm sure many of you have seen. It's health spending among developed nations, specifically the Organization of Economic Development, Economic Cooperation and Development. And the bar over here, all the way on the left, is the United States of America. So you can see it stands out from the other countries in healthcare spending. We spend about 17.5%. I think it's a little bit higher or lower now. This is maybe a little dated. Of our GDP on healthcare, including both public and private spending. So that's quite a bit, and it really stands out. But if you look at it from a different perspective, this chart compares, is kind of a similar comparison, but it includes both healthcare in the light blue bars on the bottom and what they call social care in the dark blue bars at the top. The U.S. is right here in the middle, and it doesn't stand out quite as much when you look at it this way, except for, of course, our spending on healthcare. So we tend to spend on the downstream approach once people are in the hospital, once they're sick, and you often hear people say we have a sick care system, not a healthcare system. So this is one of the reasons why we can talk about or think about spending some of our healthcare dollars and shifting them to social care, shifting them to well care. So this is a chart that I really like that was from a presentation at the Richmond Federal Reserve Bank back in September. And so what they were discussing was something called the Community Reinvestment Act. They were meeting with bankers in the 5th District, and the Community Reinvestment Act requires banks to either provide services in low-income communities, like checking accounts, loans to people living in low-income communities, or to locate branches there, or to invest in community development, including healthcare. So if you look at the left-hand chart of the chart here, it has the level of care. So here at the bottom, you're looking at patients. These would be people who are actually in your care right now. High risk, likely to become patients. People with asthma, dual eligible, senior citizens, single mothers with less than 12 years of education, and then the community level effect. And at the top, it has clinical approaches to care and non-clinical approaches to care. And you can go up the scale from 1, clinical, reorganizing care delivery, to outreach and prevention, early detection, and then finally expanding access to health care. And then into the non-clinical, the actual social determinants of health kind of phase. So interventions like integrating social services, such as they have some examples here, provide referrals or transit passes to patients so they can get to care, or write prescriptions for fresh food as Geisinger Health System does. And then you can sort of move up to non-clinical prevention care, letter mold remediation, things like Meals on Wheels, providing healthy meals to senior citizens. I was just at a meeting where we met with a rural ACO from Indiana, and they're hiring carpenters to go into people's homes and fix their high volume emergency room usage. So those are those types of interventions. And then finally, the community-wide. And what they recommend at the Federal Reserve is that you try to move up. While it's important to look at reorganizing care delivery, if you're going to have that larger effect, if you're going to move down that pyramid to have the larger effect, you need to go to 3, 4, 5, and 6. So that is a good way to kind of think about approaching healthcare from an SDOH perspective. They also have a couple of free resources, so you can click on these links here at the bottom, or write them down, take a screenshot. You can get these books for free. They're from the San Francisco Federal Reserve Board that publishes these books. You can get up to 20, and if you're going to have a community meeting with, say, the Chamber of Commerce, and they're asking the same question, how do I influence health? Why am I here? You can hand out these books, and hopefully that'll help them in their own language. You get about 20 before they start asking questions. The questions are easy. And this is another example of an index for the social determinants of health. So this is a really interesting project from the Public Health Alliance of Southern California. the California Healthy Places Index. It's very similar to the Health Opportunity Index, but a different formulation. You can see the different areas that they cover over here on the left-hand side. But what I really like about what they've done, and what we're working on doing here in Virginia as well, is once you identify a factor, let's say, that's low, say it's economic here in the neighborhood, but if it's economic, if you click on that, oops, click too soon. If you click on that, it gives you a list of actions you can take to actually address those SDOHs. And if you continue to drill down and click on these links, it will describe specific programs by different nonprofits and public health agencies in the state that address those specific problems that are happening in that community. So that's, you know, if you think about it, if you think about you're targeting your community, that's your single mothers under 12 years of, without 12 years of education, in your intervention, the earned income tax credit, $1,000, and then you get right to your outcome. So that allows you to target both the correct people, the correct population, as well as the right intervention. So that's where we're moving in Virginia to kind of emulate that kind of measurement, target to solution continuum there. And that is how we are using our information with impact to achieve health equity here in the Commonwealth. So that's all we have for you today. This is our contact information. We ran a little long. I think we started a little late, so we have a few minutes for questions. But if you have additional questions, feel free to contact us at any of these addresses, or to visit our website, which is at the bottom there. Thank you very much. I'll turn it back over to Melissa.
Thank you so much. That was excellent. So we do actually already have a few questions in the chat box. So I'm going to read those first, and then we can move to any questions that are on the line. So Vicki Booth said, a growing body of literature has found that segregation may be beneficial to health outcomes or behaviors for non-Black minorities, i.e. Hispanics and Asian Pacific Islanders. And she referenced the article by Young and Matthews, 2015. Does the Health Opportunity Index only apply to white-Black segregation?
No, it does not.
No, it does not. It takes all the race and ethnicity by success factor level. So you take every race and ethnicity to compute the segregation index.
Mm-hmm. Yes, and that would be one of the, the literature is obviously always expanding and changing. But yeah, we don't get into that level of specificity. So we like to say that the HOI shows you the landscape of your community, but it doesn't replace a deep dive or really that good local knowledge. So definitely want to, whenever you start with the HOI, drill down more deeply.
Then the next question was by Emily Putzer. You mentioned a Tableau server, but I didn't see it in your resource slide. Did that infrastructure already exist at Virginia?
Okay, so what we use for our online display right now is the free Tableau public server. So anyone can download that. You can go to Tableau's website, just type Tableau public in Google. You can download Tableau public for free, and you can use that. There are some limitations on the data that you connect to, but you can do just about everything you would need to display the level of stuff that we have in the Health Opportunity Index. You can download it in the Tableau public server. It's free, so sometimes it's slow. It crashes every now and then, but it is free, a good free service to get your feet wet in Tableau, and the software is free as well. So I highly recommend Tableau. I think it's very easy to use. There is a learning curve, but it's not huge. So if you can get someone with the experience, I think it's a great tool. Not that I don't work for Tableau or anything, but it is a very handy tool for displaying data.
And then we have a question from Michael Samuel. He praised you on the presentations today, said everyone did great work, and he was trying to see if you guys had ever partnered with the Virginia Commonwealth University. You mentioned the California tool, which they partnered with, and just wondered, had you guys at all worked with VCU?
Yes, actually the current, the acting director of the the center, Derek Chapman. He used to work here at VDH. We were actually at his office just yesterday. Was it yesterday or Monday? Yesterday we were at his office. So yes, we do work with them. I know he worked on the Healthy Places Index. Of course, we talked to him a lot about the Health Opportunity Index. The slide that Dr. Powell spoke about showing the life expectancy in Richmond was created by the Center on Society and Health at VCU. So they're great partners to us, and they do great work as well.
Are there any other questions on the phone lines now?
Ladies and gentlemen, if you'd like to ask a question, please signal by pressing *1 on your telephone keypad. And if you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. As a reminder, you may also submit your questions using the chat feature located in the lower left corner of your screen. We'll pause for just a moment to allow everyone an opportunity to signal for questions. There doesn't appear to be any questions on the phones at this time. And there are no questions on the phone lines. Please continue.
Okay, great. So we actually don't have any questions currently on the chat function either. But I had a question, so I'll ask my question. My question is, have you looked at hospitalization for health outcomes, or is any of your data linked to healthcare utilization?
Well, other than the prevention quality indicators, the ambulatory care sensitive conditions, we haven't really looked at access to care as it relates to the HOI. It's a little, one of our factors is, of course, access to primary care, so that kind of would be included in the model itself. So, but yeah, we do look at, some of the factors we do look at, diabetes, COPD, we do use hospital data when looking at that, but yes, not a specific look at access to care. That is an interesting thing that we could, might at some point do.
And Eliza Dill has her hand raised. I didn't know if you might have a question or chat question you were. Okay, I take their hand down. So could you also talk a little bit about how this tool has been used to even provide information to your legislators in your state, and how they might have used this to paint a picture?
Yes, we have shared it. We did make a series of maps for our health commissioner when they were, this was when they were, we're still looking at Medicaid expansion this past General Assembly session. So there was really a lot of interest in insurance and how it tied to opportunity and poverty, particularly in rural areas. So we did make a series of maps for specifically geared towards our legislators, our House districts, and our Senate districts, and shared those with people who were hopefully making presentations and sharing them with legislators from our agency. We also have a Joint Commission on Healthcare, which is a joint committee of the General Assembly that looks at health issues, and they, of course, have access and views the HOI when making their decisions and looking at the policies that they're reviewing to recommend out of that committee. So we do know they use it. We do know they have access to it. So hopefully it's a great tool for them.
Great. So we actually have a lot of chat questions right now, so I'm going to start just going through them all. So okay. There's one question to Virginia. Could you share details on how you measured your HOI?
We use data mainly from the American Community Survey 5-year estimates, but we also use data from some private sources as well as the U.S. Department of Agriculture, and the Environmental Protection Agency. They're basically 5-year aggregates. You kind of have to, when you're trying to drill down into the neighborhood level, you have to get those N numbers up, population numbers up to get good estimates. So we look at a time series. And then Rex has various different methodologies that he uses to combine them into different indicators. Like our segregation measure was a spatial dissimilarity index, one that we found in the literature that's linked to health. The different measures of, say, job access, we use RCIS to do inverse distance weighting, different statistical tools to put those indicators together. And then finally, we use principal component analysis to weight the different indicators when developing the profiles and the health opportunity index. But if you go to our website, we do have a detailed methodology on that site. It's kind of it's difficult to get it all in one website or one document. So there might be some questions you need to ask, and so just get in touch with us if you have additional questions.
And we'll make sure when we send out the materials from this webinar to also send a link to where that methodology is directly, so everyone on the call will have that access. Claire Adams has also asked a question. Can you share an example of a program that was created and or modified based on the development of the HOI?
So one of the things that Rex showed earlier in the presentation was our work that we did for the Maternal and Child Health Division, their home visiting program. So they were looking at low birth weight. I think you showed the maps from Norfolk. So they were interested in reducing low birth weight, so they wanted to target different areas within the county, people who might be vulnerable to low birth weight. So we looked at the low birth weight data, and then we did an analysis of that data with the HOI, seeing which factors correlated most with low birth weight. And for that particular one, it was the Townsend Material Deprivation Index. And once we overlaid the low birth weight map with the Townsend Material Deprivation Index, we really saw a good overlap that really made sense to the participants as well. So they kind of had an idea of the areas where they wanted to target their home visiting program. And those were really, when they looked at it, those were working poor areas. When we talk about the Townsend Material Deprivation Index, it's really looking at access to credit. So people who are the working poor, they tend to have high turnover in jobs. They can't develop good credit scores. It's hard for them to get loans for a car, for a home. So that's kind of what that measures. So you can really look at some of the interventions that they would then look at for that. Maybe some, some programs to help people save money. Maybe some church programs to help people get through a small period of unemployment, or credit counseling, financial counseling, things of that nature that can help people save, build their credit score, and develop some financial ability in their lives. So that's one example of how it was used. We used it for our Conrad 30 program to target where we wanted. Our Conrad 30 program is a J-1 visa program for physicians. So physicians who are foreign-born can complete their residency in the United States. Normally they would have to return to their home country after they complete that residency. The J-1 visa lets them stay in the country if they work in an underserved area. So we're able to, for 5 of those slots, identify areas. So we used our HOI to identify where we wanted those practitioners to serve as well, along with other measures of access to care combined with it. So that's the way we often use it. We don't use it alone, but we use it in conjunction with other data to help us identify what interventions we want to use and where we want to target those interventions.
Great, thank you. Eliza Dill had a question. Can you please repeat what statistical analysis was used in constructing the 30-plus variables that comprise the subsequent 13 indicators?
I'm sorry, could you repeat the question?
Sorry. Can you please repeat what statistical analysis was used in constructing the 30-plus variables that comprise the subsequent 13 indicators? Was that principal component analysis, or?
Right, exactly. That's what it is. Because That's exactly what we did. We put all the data from sensors, and because they are so noisy, we had to use the best way to reduce the noise in the data. So that's what we did. We used the principal component analysis to do that.
Great, thank you. The next question is by Anthony Arce. You state that indicators were identified by local health departments and stakeholders as important. How did the discussions in that process look like?
I'll let Rex answer that because I was actually behind one more time. How the work group? So basically, how did the discussions go with the work group?
Oh, the work group, yeah, exactly, yeah. In fact, it was very productive. We did have a work group, and then we discussed lengthy how it should be constructed and all the other resources that we have. So it was very productive, and we were able to help them to really advise them, to inform them what is actually going on in the landscape of their area.
It was a somewhat informal discussion, as I understand it. We didn't have like a formal survey or anything of that nature. We just had a few meetings with stakeholders who were interested in attending, and just came up with a list of indicators that people felt were important for health in their communities.
And then one question is, could you talk about your experience using Tableau? Any experience, any issues outside of it sometimes having glitches due to the fact that it's free? What are some of the what was your experience? Any challenges with using that free tool, Tableau?
I said there's a short learning curve, and there is a short learning curve to do some of the basic work in Tableau. However, if you want to do anything moderately complex, it becomes really an exercise in problem solving and researching in the different community forums to identify different methodologies. So it's very easy to get started. It's very hard to really master in the end. And it requires kind of some unique kind of thinking about data and how you structure the data. It prefers more of a database arrangement than our normal spreadsheet with columns and rows that you think about. This getting a little bit technical, but you kind of have to think about the data a little differently and how you use it. Once you get it, it's a tool for design for visualization. It's also a very handy analysis tool as well. But those interactive visualizations, once you get them online, people really like those. It allows them to explore. It allows them to answer some of their own questions and to develop new questions, more deep questions, I believe. Yeah, it is really a handy tool for that. And again, I don't work for Tableau. Okay.
And then, so we have some more coming in. Can your data be linked to county-level prevalence data?
Yes, you can do that. In fact, you have to weight them by the population using a geometric mean. The population to be able to, like I said earlier, the census tract and the county are coterminant. Therefore, you can weight them up to county level. But they have to be weighted to county level.
And then the final question I have in the box is, are each of the variables assessed for the index? I think you might have just answered that, but are each of the variables assessed for the index weighted the same, or are certain variables given greater influence in the final index scoring?
No, actually, the weights are based on the interaction effect of all the 13 indices. Therefore, they are not arbitrarily chosen. They are based on the parameters in the model. So we don't, that's where just like a regression, you get the betas or the parameters and helps you to weight them. And then so there are no artificial weighting here. It's all statistically determined.
Yeah, and the weighting is formed using the same tool, principal component analysis.
Yeah.
And then one question was, is it possible to share some of these social determinants of health measurement tools?
Yeah, in fact, yes, it is possible. Yeah, in fact, we use SPSS to do that, but like I said, the only one that is more complicated is the one the segregation index one, which is more complicated. The rest are okay. The rest can be done in either in SPSS or SAS or even Excel if you're very good at Excel. So they're pretty easy to use in Excel. But if you have a SAS or SPSS, make it more easier.
Okay, SAS or SBSS?
Yeah.
Okay, great. And then we have one question just came in from Linda Schultz-Lewis. What is the smallest county population that can be used and still get statistically significant results? And then the second part would be, can this be meaningful for smaller counties and or counties with small numbers of racial minorities?
Well, I'm pretty sure the question is asking if, because we don't do a county, we do the census tract level, but census tract level, because they are weighted based on the space. So space is we take space into account. Therefore, not only that particular census tract, but its neighbors. So you get a weight, or you get in other words, you get it's influenced by your neighbors. Therefore, at the census tract level, if it's county level, I bet you probably it's okay by county level. But census tract level, you use spatial analysis. Therefore, it takes the census tract and its neighbors to compute the parameters.
Yeah, and we increase our insights by using that 5 years of data. So you lose a little bit of timeliness that way, but you gain a little bit more, a better ability to drill down.
But I would suggest that nobody wants to do that, use the 5-year estimate. That's a more stable rate than the 1-year estimate.
Well, this is great. We got great question and answer segments, so that was great. And so we will, if you guys have any more additional questions, if you send them to me, I can direct them to the Virginia panelist team and make sure you get your questions answered. I wanted to talk quickly about we have an upcoming ASTHO Health Equity webinar in June. It's June 15th from 1 to 2. And so on our website under ASTHO events, there will be a registration page. You can also register by clicking on the slide. We'll make sure the slides get sent out. It has a hyperlink. And then I also just wanted to thank everyone for their participation today. And I wanted to really just thank our excellent panel speakers. I would like to, thank Dr. LaBird, Dr. Powell, Justin Crow, and Rex Anson Dwamina. I'm sorry if I pronounced that wrong. For your enriching presentations. I think this was excellent. We're getting great feedback from participants in the chat box. So we really thank you for your time. And we think, we also would ask that you please complete the post-webinar survey. If you look on this last slide, thank you for joining. There's a hyperlink to the survey. We would really appreciate your feedback. It will help us to continue to design educational opportunities and webinars in the future that are useful and practical. There's also, we've provided the email addresses to the various speakers, and then also a link to our webpage, ASTHO Center for Population Strategies Health Equity page, for more resources and information, and also that's where you will find the map for examples of how states are working to address and achieve health equity. And the last thing I wanted to mention is that we also have a June 1st edition of the Population and Prevention Post newsletter coming out. If you are not on that listserv, please send me an email and we will add your name. And that combines information on health equity, community to clinical connections, our data and analytics, as well as all of our health prevention activities. So please sign up for that webinar, and thank you so much. We will make sure that you guys get the slides ASAP, and that way you'll be able to access the different hyperlinks. And because I think right now you probably can't access the way it's in the system. And we will send that out this week, and then you'll also get a copy of the recording, the slides, and any other materials next week posted online. So thank you so much for this information, and we'll definitely send out the PowerPoint slides, or at least the links, so that you can have the contact information and for the emails and registration page, so you'll have that information today. So have a great and safe Memorial Day weekend. And thank you again to the speakers for presenting.
Thank you.
Thank you.
Thank you.
Ladies and gentlemen, this does conclude today's call. Thank you for your participation. You may now disconnect your lines.
Thank you.